Hello, happy Friday. We are taking a few secs to let everybody in, but we are happy to have you here. And we're really happy to have Emily Cook with us. I'm going to also share slides, and Shanta is going to be managing attendees, and we will get started. Okay. Let me see if I can do this. All right. So today we are talking about broader healthcare implications that go beyond what the 340B Act and its kind of accompanying rules that are associated with it might have on your program. We are so happy to have Emily here. She is a partner at McDermott, Will and Emery, and we have been peers, colleagues, I don't know what we want to exactly call it, for a really long time. We've both been in the game for about the same time and know each other for a long time. So it's always fantastic when we can have guests that we know that we can trust and rely on and go to about strong and solid legal advice. So Emily she's been here, been around for over 2 decades, and we can read this, but I think that it's always fun to talk to people about how they got into 340B. And so, Emily, I know that we had prepared this in advance, but back in your days, we've kind of flip-flopped. Now I'm in Denver. But you started out working as a project officer in the Office of Rural Health Policy for OPA, and then came into the legal side of 340B right when multiple contract pharmacy was starting. So I think that you've seen a lot, you've done a lot, and we're really happy to have you here.
Yes.
Yes.
Happy to be here.
Amazing. So today what we really wanted to talk about, and I'm going to let Emily do a lot of the speaking on the different risk areas that intersect with 340B that we at RxX, like we come into this all the time where we'll have the 340B manager or director or whatever kind of level you are asking questions about, is this permissible under 340B? And those are kind of things that we can help say yes or no to. We can go to a 340B attorney and say yes or no to. But there's several other laws that really impact the overall picture of how you're operating. So while the answer may be yes or no for 340B, we may have to put the kind of framework or the scenario that you're wanting to do. We'd have to pass that through other healthcare laws and rules. So that's what Emily's here to help talk about today. So Emily, I don't know if you want to start off or if there's any other introductory comments you want to make.
So I will note, as Madeline mentioned, if the only question you're asking about a particular arrangement that you are contemplating or are already involved in the 340B space is this allowed by the 340B program? That is really not enough to determine whether you can, quote, actually do something. There are many other federal and state laws that are involved in really every aspect of operating a 340B program. And whether or not a particular arrangement or program can be done under the 340B statute is in some ways the last question you should be asking, not the first, and certainly not the only question, because many of the other laws that apply have significantly more concerning enforcement penalties. And while I know everyone may be concerned about losing access to the 340B program, being excluded from federal healthcare programs is a much larger concern. And so I will say that today's presentation is probably going to be a little scary and uncomfortable to many of you, but I can assure you it is less scary and uncomfortable than receiving a subpoena from the government. So, again, many of you, this may not be your specific area of responsibility. This may simply be an exercise in issue spotting for various concerns to bring to other folks within your organization. But it is really important for folks in the 340B space to understand all of the other laws that touch on the work that you do. So we will start with one that is, I will say, in the realm of most scary of the other laws that apply to 340B arrangements. And I will say is often also one of the most overlooked because there's a lot of nuance. So the federal anti-kickback statute prohibits payments or remuneration between parties to induce referrals for services that are reimbursed by federal healthcare programs. The penalties can be extremely draconian. There are civil fines that can be in excess of $27,000 per claim, and that adds up extremely quickly. There are criminal penalties that can be imposed, and as I noted in the intro, exclusion from federal healthcare programs, which means that a provider is no longer able to receive any payment for any purpose from any federal healthcare program for a period of time. Where this comes into play in the 340B space is typically, I'm not going to say exclusively, but is typically with various types of vendor arrangements in the 340B space. Mostly vendor arrangements that I see that have potential AKS concerns are those with third-party vendors that are operating a pharmacy or some other type of service for a, again, typically hospital, but not exclusively, related to their 340B program. And the compensation that is provided to the vendor is tied to a percentage of 340B revenue. Or alternatively, the vendor comes in and says that they will set up a new specialty pharmacy at no cost to the covered entity. And this may include, in some cases, providing the entire cost of construction of a building or purchasing the entire initial startup inventory for the pharmacy. Those are arrangements that I'm not going to say that in all instances are absolutely prohibited, but they very much require careful review and an understanding by the organization of the risks associated with those arrangements. Similarly, joint venture pharmacies, which are arrangements under which, again, typically a hospital, but not always, will partner with a third party to establish a new legal entity that operates, in our example, as a pharmacy. If those arrangements rely entirely on referrals from the covered entity, again, there is a need to ensure those arrangements are evaluated for potential kickback risks and that the organizations understand the risk profile of those arrangements. So it's very important to evaluate all vendor agreements for kickback compliance, but particularly those that involve percentage fees, free services, or referral arrangements, and to ensure that those compensation arrangements are consistent with fair market value. In other words, they are consistent with the marketplace compensation that would be provided to the vendor if it were an arrangement that were being paid on a fixed fee basis and not a percentage fee. So Madeline, do you want to talk a little bit about what you see in this space in your work?
Yeah, I think that what we see are questions about, in particular, there's this idea of what about when it gets down to the patient? Can we, and I don't want to use the word induce because that's never what's used, right? It's like, how can we get patients to use our services? How can, what comes up in terms of referral arrangements with, this idea of referral for capture? We see a lot of scenarios where I'm like, is this really a referral? Or is this kind of circular in some way? Or what are you getting out of it? I think that's the good way to test this, is like, what's being provided and what are you getting out of it is a good litmus test, because sometimes it might seem like, oh, well, this is normal, right? Like I would expect for these types of patients to automatically come to my pharmacy, and we're going to reduce all their costs, or we're going to do something for free. And
Okay.
and
Mm-hmm.
right.
Yeah. I'm so David.
Sorry, just going to mute everybody for a second. And then Suzanne, Shanta, maybe you can help unmute. Oh, did I mute myself? No. Shanta, can you unmute the other? I know I'm crazy. Can you mute the others? Thank you. So I guess what I'm trying to say is some of these referrals that have kind of this idea of remuneration, like what am I getting out of it? They're really important to consider in terms of this anti-kickback. You don't want to make it look like you're financially invested in this idea of we're going to get paid by Medicare or Medicaid in particular for this service.
Sure. And I think those are all extremely important concepts. We'll talk a little bit more about them in the patient inducement section.
Right.
But the patient inducement rules we will discuss are very closely tied to the kickback prohibitions, and often arrangements will fall into both categories. So it is very common for inducement arrangements to also be alleged to be kickbacks.
Right.
So you have to always make sure you're monitoring both of those when you're looking at referral arrangements.
Yeah.
If we can go to the next slide. The False Claims Act really underlies many of these concepts and addresses circumstances where claims that are false, that is, not factually correct, are submitted for payment to the federal government. But there are a lot of circumstances that can create false claims that may not be directly apparent. So it is not just a matter of ensuring that all the letters and numbers on the claim are correct. If the claim is submitted for services that were provided inconsistent with federal law, that can also create a false claim. So, for example, the anti-kickback statute that we just discussed, if a claim is submitted for payment and the service associated with that claim violates the kickback statute, that can render that claim a false claim. And false claims are subject to civil monetary penalties per claim, again, treble damages, and can be subject to criminal prosecution as well. Some examples of circumstances that create false claims are, and these are some of the more, I will say, apparent examples where there is factually incorrect information on the claim. Billing state Medicaid programs in excess of the 340B actual acquisition cost when the state requires submission of the claim at actual acquisition cost. Incorrect attribution of Medicare costs to establish child site eligibility. There are rules that apply to when you can report Medicare allowable costs and charges on the cost report. Those reporting of Medicare allowable costs and charges are typically what are used to establish child site eligibility. You can't just decide that you are going to report certain costs and charges in a Medicare reimbursable cost center. There are rules that apply, and failure to comply with those rules can result in submission of an incorrect cost report that is considered to be a false claim. Similarly, reporting false metrics for dish eligibility is also potentially a false claim. In other words, even if a particular dish metric is not going to be relevant for payment from the Medicare program, but may allow for establishment of 340B eligibility, submitting a cost report with that information incorrectly stated can result in False Claims Act violations. So it is extremely important to understand that there are regular audits being undertaken of both claims and cost reports, and that staff, and including, again, in some cases, pharmacy staff, if you are closely involved in cost reporting concepts related to 340B eligibility, are trained and understand the rules associated with cost report filing and claims submitted to the government and what the consequences of getting that information wrong can be.
Right. Really, I mean, like this is one of them where, when we were at the IG's office, when Suzanne and I were, like, usually the things that got to this level of false claims were things that were knowingly being done, like scams, stolen social security numbers used to bill for people, upcoding intentionally, nursing homes. There's usually that kind of what I would classify as outright fraud, where there's like a scheme behind it, right? And in these situations, I think it can be much more subtle, and therefore Emily's kind of examples are really important to think about. Something that comes to mind for me is, and Emily, you'll be able to speak more on this, but we don't want to represent that we are providing a service that is hospital based or that is, entity based for our FQs that are on the phone. That really isn't, right? Like, just because a service exists doesn't mean that it's hospital based. So I think that's something that we have to um, consider when we're looking at false claims.
I think that's right. There are certainly scenarios that have come across my desk where a 340B covered entity would very much like for a particular location or service to establish 340B patient eligibility or to establish eligibility of the location as a child site. And there are ways that I will say, as a paper exercise, you can give the appearance that certain services or locations are eligible for the 340B program. The problems associated with that are not just 340B problems. There are rules that govern when you can report something as a hospital service, and we'll talk about those in a moment. They also apply in some circumstances to grantee covered entities, and you don't just get to report things where you want to report them when you want to report them that way. If you don't follow the rules, that again is going to create a very high risk of False Claims Act liability.
Yes.
So we touched on the patient inducement laws just a bit earlier. The patient inducement laws are an expanded version of kickbacks directly to patients. And these exist both at the federal and at the state level in some states, and in some states actually expand beyond federal healthcare programs. The general rule is pretty easy. You can't give patients anything of value that is going to influence their choice of provider. That could be money, that could be gift cards, that could be some form of extra entertainment activity. There are a wide range of things that can trip up patient inducement laws. And it really isn't a matter of whether the entity offering whatever the thing of potential value is believes it has value. It's whether the patient believes it has value. So you could print up a whole bunch of tote bags that on average cost a few cents each. But if a patient believes that they really want that tote bag and access to getting it is going to influence their decision to choose you as their provider, you could have an inducement risk. I will just as a footnote note, there are some safe harbors for remuneration below certain levels. And so, again, there are some ways to protect yourself from low cost items being provided, but the analysis really needs to take place anytime something of value is being offered. Routinely providing discounts or free services is a significant patient inducement risk. And this is actually an area where I get very frustrated with drug manufacturers in the 340B space for many, many things. But one of them that I get frustrated with them about is their constant suggestion that 340B covered entities can just provide 340B drugs to patients either for free or at the 340B cost. They
Yes.
can't. That is a high risk of inducement or kickbacks. There are circumstances where drugs can be provided at no cost or at reduced costs, but it requires going through a very specific analysis and ensuring that there are all sorts of specific requirements that are met. So for example, if you have a financial assistance policy, you can provide discounts on a sliding fee scale or based on specific income thresholds. It has to be applied consistently, and it has to meet other additional requirements. So as an example here, a potential inducement risk would be financial assistance policies that address only high-cost prescriptions and only waiver of patient cost sharing. So the goal in these models would be to encourage patients to get their prescription for a high-cost drug filled at a pharmacy where 340B drugs can be used because the drugs are lower cost, and the claim is then submitted to the patient's payer for payment of the vast majority of the cost of that drug. Again, there are circumstances where you can provide things of value, where you can waive cost sharing, when you can provide discounts, but it has to be done under very specific circumstances. The issues here really are generally going to be managed, I would say, outside of the pharmacy, although sometimes pharmacy folks get tasked with pharmacy-specific policies, which can be a little bit concerning because they, in many cases, need to tie back into various concepts and policies of the covered entity that are likely managed outside of the pharmacy. But generally, anytime you are giving something of value to a patient, it needs to be subject to review for compliance with inducement and kickback laws.
Yeah, and I think you hit upon what I was going to say is when faced with this constant messaging about how charity care is bad or how the drug price and discounts and copay assistance needs to just automatically be like it's a given. I don't think there's any consideration of this. And so when we've worked with covered entities to try to set up a revised patient financial assistance program or really have a good hard look at what are the options for the patients, this does come up all frequently. So it's not just as easy as, of course we can pass this on. There are all these there's sizable rules and impact about what would happen if you are just forgiving patients' copays or reducing them without really strong guidelines around it.
We can move to the next slide. Our next slide is on Medicare provider-based rules and conditions of participation. And I will say these are the ones that probably come up the most often when I am working with 340B hospital covered entities. But again, there are concepts here that also apply to grantee entities when they are looking at whether a particular location or service can be considered part of the 340B covered entity and eligible to participate or provide access to 340B pricing. The Medicare provider-based rules are a condition of payment, which can tie back into our prior discussions of the False Claims Act. The Medicare conditions of participation are rules that relate one of the maybe main areas that you can see would be participation. So if you violate those rules, it can result in termination of the Medicare provider agreement and therefore the ability to participate in the Medicare program. The provider-based rules govern what locations can be considered part of a hospital and billed to Medicare as a hospital. And again, for FQHCs, these are going to apply in some cases as well to a determination of which locations can be considered part of the FQHC entity for Medicare purposes. And the conditions of participation, and again, there's an analogy for grantees, are going to govern a lot of operational concepts to ensure that a particular location is in fact operating as part of the hospital or grantee entity. So some examples that can create some risks, and one that I've seen very frequently, I would say in recent months, as we're seeing an expansion of some of the pharmacist-driven clinical care models, including medication therapy management provided as a hospital service, is that the conditions of participation provide for a significant level of authority over hospital clinical care from the hospital's clinical leadership and the medical staff. So when you are looking at who can provide services as hospital services and where they can provide those services, it is, I would say, not just important, but required that you are consulting with the hospital or grantee clinical leadership to ensure that they understand what the plans are, what the program is, and that it's consistent with their rules. Many hospitals, for example, require that pharmacists providing clinical care as a pharmacist clinical service be credentialed by the medical staff and follow medical staff rules and bylaws. There are also rules associated with who can order hospital services. Often in hospitals, those are not going to include pharmacists. So any service that is provided as a hospital outpatient service, again, in most cases, will be required to be ordered by a practitioner who can order services at the hospital, and those are typically going to be physicians. Similarly, these rules govern various types of referrals and services and facilities shared between providers. So there are rules that determine when a hospital can enter into a contract with a third-party provider to provide services on their behalf that are governed under the provider-based rules and conditions of participation. And similarly, when you have two different provider entities operating in the same building, or in the case of Medicare, even on the same campus, so within 250 yards of one another, there are rules that require various differentiation between those two entities, and in some cases prohibit sharing of resources that in any other normal business context would be clearly shared for various cost savings and efficiency reasons. But even if they would result in cost savings and efficiency to federal programs themselves, oftentimes those federal programs prohibit certain types of sharing arrangements. The other one I just want to hold out is an issue that arises because of some confusion under the 1996 patient definition. The hospital conditions of participation govern hospital medical records. There are very specific rules associated with the circumstances under which hospitals maintain records of patients' care. And it is very difficult, if not impossible, to take the position that certain types of records of care that are not being managed by the hospital under those medical record conditions of participation are actually records of care that is provided by the hospital. So oftentimes we do hear of arrangements where someone is putting a great level of emphasis on the 1996 patient definitions reference of maintaining records of a patient's care. We know that HRSA wrote it flexibly for circumstances where a provider may not be subject to rules that specifically govern the way in which they maintain patient records. Hospitals are not one of those providers. So particularly for hospitals, you have to ensure that you're following the rules associated with hospital medical records, and those are the records that are considered to be records of patient care provided by the hospital. Again, in terms of non-compliance here, fines, termination, again, potentially overpayment recovery and False Claims Act violations can all occur. This is very important. And I will also note there was a legislative proposal in December that almost passed into law that would have required all hospitals to effectively prove up to the government that all of their off-campus outpatient locations complied with these rules. Many hospitals, I will just say this, operate locations that may not apply or may not comply with these rules. It is critically important that if you have hospital outpatient locations, that someone is actually reviewing them to make sure that they are compliant with the provider-based rules and conditions of participation. We are expecting that at some point in likely the very near future, Congress will successfully pass into law a requirement that provides significantly more oversight of compliance with these rules.
Okay, that's really interesting. I think that, Emily, you probably get asked this all the time, because this idea of what are the three parts of patient definition, and pharmacists are healthcare providers. So we're like, okay, great. But then this next layer about, are they credentialed? Do they have certain rights and privileges in the hospital? I think that's a really important thing for people to consider. So that's probably something that we get asked it a lot. And I would just say that, this is a great example of where If you only stick to 340B rules, you may be missing out on your complete risk assessment.
That's right. And in fact, the provider-based rules are so important. We've got them here again to address some other requirements under the provider-based rules. So we just discussed some of the more operational requirements of the provider-based rules, but there are certainly other circumstances in which we see them arise a lot. And I really want to emphasize the first bullet here under key challenges. It takes a long time to ensure compliance with the provider-based rules at a new location, whether it is a de novo location that's been built from the ground up or a physician practice that is being converted to a provider-based location. I am asked more frequently than I feel really should be occurring to assist in legal evaluation of conversions to provider-based status for 10, 20, 30, 40 locations at a time in sometimes weeks. So someone will say, our cost report is going to be filed at the end of this, or our cost report year closes at the end of this month. We have to get these locations on our cost report as child sites. We need to make them provider-based before the end of the month. I will just tell you, every single time I have been asked to do that, I have said no. I am sure there are other attorneys who have a different internal risk tolerance who may be willing to help with this, but I can tell you from having worked on many provider-based conversions, you cannot do this in a matter of weeks. There are some practical requirements that prevent you from doing this in a matter of weeks. So if you have, for example, a physician practice that you're converting to a provider-based location, two of the requirements that you will need to meet, among many others, are that the medical record systems of that location need to be integrated with the hospital, and there has to be permanent signage that indicates that that location is part of the hospital, the specific hospital to which it is provider-based. It is oftentimes, and I am not exaggerating this, a 12 to 18 month process to integrate a new location into a hospital's medical record system. Similarly, it is very difficult to order, have delivered, and install permanent exterior signage within a matter of weeks. You might be able to get some vinyl letters to stick on the door, but you're not going to be able to replace the actual entire set of wayfinding signage, or again, any signage that may be on a marquee on the side of the building, in front of the building, as a directional sign from the road. And all of those have to make it very clear that that location is part of the hospital to which it is provider-based. We've done attestations, which are voluntary, but do require submission of information to the government that they review and use to determine whether a location is in fact compliant with the provider-based rules. And we have on several occasions had provider-based attestations returned because either the Medicare contractor or CMS viewed the signage as not permanent enough. So this may sound like a silly thing to focus on, but it is extremely important. Similarly, from a timing perspective, provider-based locations have to comply with state hospital licensure requirements. There are some states that do have hospital licensure processes that are very, very quick. There are other states that have hospital licensure procedures that can take months. You cannot operate a provider-based location as part of a hospital unless it is on the hospital license in a state that requires that it be on the hospital license. So again, while there are some states that do have rapid licensure rules, that is certainly not all of them. Similarly, the location has to be part of the hospital's Medicare enrollment record. So that's the 855A. So that has to be submitted and approved as well. And also, if the hospital is accredited by one of the accreditation organizations that has deeming authority, that is, they're reviewing for compliance with the conditions of participation on behalf of the government, the location has to be added to that accreditation record as well. So again, I really cannot emphasize enough that it is not a quick process. No matter how much you want to have a location appear on your cost report, you cannot have it appear on your cost report until it meets all of the provider-based rules. And that often is going to result in a time frame that is not going to be weeks. And in our experience is often, as noted on here, 9 to 12 months. I will also note joint ventures cannot be provider-based. There's some language in the provider-based rule that suggests you can have an on-campus provider-based joint venture. I can go on at length about why you cannot have a provider-based joint venture, but the very short reason is that provider-based locations have to be under the Medicare enrollment and hospital licensure of the hospital to which they are provider-based. And the Medicare rules do not allow for you to enroll a location as a location of a hospital if it does not have the same ownership, the same exact ownership as the hospital. So you cannot have a separate legal entity joint venture on a hospital's enrollment application. And similarly, under the state licensure rules, there are limitations on having locations that have different ownership under the license of a particular hospital. So again, this is one area that I am particularly passionate about and just really encourage everyone to think thoughtfully about compliance, particularly in light of the likelihood that we're going to see increasing government oversight in this area. And I do anticipate that there will be quite a lot of provider-based locations that lose their eligibility for both the Medicare program and 340B once those rules are in place. And I think it may have occurred after Madeline and Suzanne were with OIG, but in 2015, OIG did a review of hospital compliance with the provider-based rules. And I will just say the results of that were that many hospitals operate locations that are not consistent with the provider-based rules, and there were quite a few hospitals in the course of that OIG review that were forced to make changes to locations or terminate them from their Medicare hospital enrollment.
Right. I mean, I think it's kind of like, when you have in your mind, I'm going to redo this bathroom and it's going to be super easy. And then you're, 6 months in and you're like, where's the sink? Right. I mean, it's a much more complicated process. And I think when we're dealing with the 340B team and not kind of this broader stakeholders, sometimes it can be really underestimated. The timing of it can be very underestimated. Like, well, we'll just do this, and there's a lot that goes, a lot that's in the project plan. Let's just say that a lot of dependencies, and then you're also dealing with uh, just there's the state and federal that you're dealing with in terms of paperwork. Dan Peters asked, are you certain that signage required under COP to be on the outside of the building? This is not always possible if it's provider based within a medical office building.
So the signage requirement is under the provider-based rules, not under the conditions of participation, just to be clear. And actually that means it makes it a condition of payment rather than a condition of participation that can be more easily addressed. The short answer is it may be that in a particular instance, signage is not required on the outside of the building. The actual requirement that ties to the signage that the government reviews as part of a provider-based analysis is part of the patient awareness requirements. So the rule under the provider-based requirements is that a particular location being treated as provider-based must be held out to patients, the public, and payers as a location of the hospital to which it is provider-based. And exactly what is required for that is to some extent up to the particular provider, although again, we know that the government has very specific expectations. So if there is exterior signage on the building, then it may require that it be changed. If there is an outside patient wayfinding signage post, that will definitely require changing. Medical office buildings are actually sometimes more complicated than standalone buildings because when you have multiple providers in the same building, you have to make it even more clear to patients that they're receiving hospital services and the particular hospital that they're receiving them from.
And what we see is sometimes in a system where there's one hospital-based department that's inside a separate hospital. I mean, that it can get really confusing. Or when there's system and then entity, various hospitals within a system, keeping clear of who's who can be really hard.
Yes, I will note we'll move past provider-based, although I
It's
will
not
say I could talk about it at length all day. And in fact, my firm is having a webinar. I'll be presenting with some of my colleagues on March 17th to talk even more about the provider-based rules. If you're interested in attending, it's free. You can email me my email. I'm not sure if you all received it. It's ecook@mwe.com, and Madeline can certainly get it to you as well, and I can send you the link to register.
awesome.
Okay, state level compliance. So we've been talking mostly about federal rules so far, but they are, again, not the only rules that apply, and there are many state rules as well. And the challenge with state rules often is that they are less clear, less publicly available than Medicare rules. And also for entities that operate in multiple states, it means you have to comply with rules in multiple states. So each different state has different rules, and we're going to talk about them generally today because we don't have time, or quite frankly, I think the mental capacity to discuss 50 plus different sets of rules. But do keep in mind, each state has very different rules, both for fraud and abuse compliance and Medicaid billing. So the Medicaid requirements are different in each state and must be understood for each state. So if you are a provider that does bill out-of-state Medicaid programs, you have to understand each individual out-of-state Medicaid program's specific Medicaid billing rules. You don't get to apply your home state billing rules to other state Medicaid programs. And there are also other common laws that apply, and we'll talk about those in a minute. But that is another area of state level compliance that I think increasingly I'm seeing come into play in 340B arrangements and seems to be overlooked. There are basic laws. I think everyone knows them. You don't have to be an attorney to understand theft, fraud, misrepresentation. And 340B programs are not exempt from compliance with those basic concepts as well.
Yeah,
And
I
I
think
think yeah, go ahead.
I've never even thought about that. So that's really interesting. Are there any examples like this common law that might apply?
Yeah, so I think we've got a slide in a little bit that will discuss some of those, but
Great.
I'll just say at a high level before we get to that so people can be thinking in case you have specific questions. Anytime you are engaging in an activity that involves the generation of reports or documents or invoices that include information that is not factually correct, you need to make sure you understand who is using that information, how they're using it, and how that intersects with your state criminal laws.
Okay.
So state fee splitting rules. These are, I will say, getting, again, pretty far into the weeds of various rules for compliance, and one that I think it is unusual for folks at the pharmacy level to be familiar with, but certainly something at organizations that are in states with fee splitting rules, something that the compliance and legal departments should be very familiar with. These relate to circumstances similar to the ones we spoke about under the federal kickback statute, where vendor payments are tied to a percentage of billed claims. So if there is an arrangement under which a vendor gets, for example, 10% of the revenue collected on services for which they are providing support and are billing to a payer, that can violate fee splitting rules. Similarly, referral arrangements that involve back-end provision of a percentage of collections to the referring party can create challenges under state fee splitting rules. So an example would be if a particular arrangement between a pharmacy and a physician said to the physician, hey, physician, if you refer your patients to our pharmacy, we will give you 10% of the amount that we receive in collections from a payer for each patient that you send to us. That is likely going to violate kickback laws, but also may violate state fee splitting laws. One of the ways that many states and the federal government look at these arrangements, again, is whether or not the compensation being provided under these arrangements is fair market value. So again, it's often important to make sure you understand at the global level, what is the compensation being paid under a particular arrangement or a particular vendor? And is that in line with what would be paid to that party if the arrangement were not a percentage fee or a split of revenue, but were instead a fixed amount on the basis of the expected services that they're providing.
Okay. I'm learning a lot. Even though we help make these
There are a
slides.
lot of rules. So we touched on it a little bit earlier about state Medicaid billing rules. I will say state Medicaid billing rules are one of the areas where we're seeing increasing attention from the government. There have been several high-profile self-disclosures of overpayments related to improper Medicaid billing that I believe got the attention of certain state governments as well as federal agencies. The one that I think has prompted a lot of the attention on state Medicaid actual acquisition cost billing compliance and the way in which that it generates overpayments from federal programs is the Memorial Care settlement from, I think, 4 or 5 years ago now. Memorial Care is a system here in Southern California where I am located. And they had identified internally that they were billing 340B drugs in excess of actual acquisition cost to the California Medicaid program, and ultimately self-disclosed those overpayments to the federal government and entered into a settlement agreement with the federal government in which they agreed to pay over $30 million to the federal and state government. So it was a lot of money. These add up really, really fast. And at least in the view of the government, are one of the more easy to identify and potentially take enforcement action on billing issues, because often the rules are bill at actual acquisition cost and you will be paid at actual acquisition cost. And if you bill in excess of actual acquisition cost and are paid in excess of actual acquisition cost, that is likely an overpayment. And if not promptly returned, again, can result in False Claims Act violations under federal and state laws.
This is a really good example of where the 340B team's responsibility can fall off a little bit, meaning that when HRSA does an audit, when they request their data, when they look at their claims, when they come on site, they're not looking at this kind of layer, right? They're looking at the NPIs, they're looking at who the payer is and all of that, but they're not looking at whether AAC was charged correctly, right? That's kind of, to them, that's not part of their federal responsibility. But for our clients that are located in states where AAC is required by the state, this adds another layer to it. So I just don't want that gap in HRSA audit preparedness versus, state preparedness to kind of go unmentioned. But we do see that kind of layer of AAC or modifier application. Not to say that it's not looked at, but I'd say that the AAC component of it is more challenging than the UD or whatever the modifier is audits.
Yeah, I think that's right. And I do want to actually make sure everyone is aware of one interesting nuance here. In the 340B space, because most folks who work directly with 340B programs are not Medicaid billing experts and are not tasked internally with understanding Medicaid billing rules, there can often be a misunderstanding of the purpose and role of actual acquisition cost billing. Actual acquisition cost billing in the 340B space really has nothing to do with duplicate discounts. It is not a duplicate discount risk or issue. It is a Medicaid billing issue related to the amount that a provider is paid on a claim.
Yes.
And it is in the bucket of, again, federal and state enforcement activity related to overpayments and false claims, not duplicate discounts. So as Madeline mentioned, we do have circumstances where people will say, well, I don't understand why you are concerned about my Medicaid billing. HRSA did an audit. They looked at our claims. They didn't flag anything as wrong. That's because HRSA was not looking for your compliance with federal and state billing rules related to the amount you are paid. They are just looking for duplicate discount compliance. And simply because HRSA did not flag any issues does not mean those claims are okay
Yes.
for all other federal and state laws.
Yep. I think that's spot on.
Okay. So I know we only have about 9 minutes left, so we'll try to go fairly quickly here and hopefully have a little bit of time for more questions.
Yeah, and
As I noted, oh, go ahead.
say, if you have things you want to put in the chat, please, or the Q&A, please go ahead. But go ahead, Emily.
Sure. So the state fraud and unfair business practices laws, as I just mentioned, are something that, quite frankly, until a couple of months ago, never really crossed my mind to highlight for folks, because I think I maybe incorrectly assumed that everyone knows you should not be engaged in various types of unfair business practice, theft, fraud, misrepresentation. But as it turns out, there are some current 340B arrangements out there in the marketplace that involve components that I think actually, for those folks who are contemplating them or have implemented them, it has also not crossed their mind that what they are doing may be inconsistent with common laws, criminal laws, unfair business practices. So I will just emphasize, as I did previously, if you are contemplating or have entered into an arrangement that involves generation of factually incorrect documentation, you should take a very close look at your comfort level with that arrangement. For example, if you are involved in an arrangement that involves the generation of invoices for 340B drugs that suggest drugs are being shipped to a particular location, and either the drugs are being shipped to a different location than the one on the invoice, or no drugs are being shipped at all anywhere, you should make sure you understand exactly what role that invoice is playing, why it is being generated in a way that is not factually correct, and what the risks associated with that arrangement might be.
Woo. That's a good one.
So there are a lot of scary things we have spoken about. And again, I assure you, as scary as they are to talk about now, they are even more scary when the government comes knocking on your door. So it's important to get ahead of them. And the easiest way to ensure compliance is to, number one, understand the rules. Number two, understand who within the organization is responsible for compliance with those rules. And I will tell you, in almost all cases, it is not going to be the 340B subject matter team at the organization. That is not something that the 340B team should be tasked with. It is something that should be a responsibility of others within the organization, but there is unfortunately oftentimes a view within organizations that anything that is associated with 340B is a 340B issue and the responsibility of the 340B team. It is important to conduct routine audits for compliance, to have clear policies and procedures, to make sure that issues are appropriately elevated internally when any concern arises, and that there is very clear documentation and, where needed, appropriate legal memos to support various transactions and decisions that are being made.
Yeah, and I just want to mention that, Suzanne and I get asked all the time about legal questions, and we always say, we're not lawyers, we can't do this for you. So I would say that if you're, one of our clients, you've heard this from us a million times, we may say, here are some questions you need to ask your attorneys. If you're not our clients, I would just say that over-reliance on consultants who are not attorneys or who are not, subject matter experts in this one particular thing. Sometimes I hear from our clients like, well, this consultant told me I could do this. And so I would just caution you to make sure that you're getting to the right source for your information. Yeah. And fact checking, you can crowdsource your consultants, it's all good. But I think at the end of the day, making sure that awareness of these other laws is really important. You don't have to be an expert in it, but just know that there's more than just 340B.
Yeah, I will say on one of those points, your vendors are not your attorneys. Right. They are not looking out for your interests. the vendors that you're contracting with have their own separate risk profiles for the arrangements that they're entering into. And oftentimes the arrangements in the 340B space may have risks that run solely to the covered entity involved in the arrangement and no risks running to the vendor. And it is always important to understand that the vendor could very, very easily be suggesting an arrangement to you that is entirely outside the scope of one or more federal or state laws. And to some extent, it is not their responsibility to ensure that they are presenting compliant arrangements. It is the responsibility of the covered entity to ensure that they understand the legal concepts involved, they understand the risks, that the arrangement is properly vetted internally, and that ultimately, if there is enforcement action, who will be subject to that enforcement action? And again, typically it's going to be the entity that is responsible for billing the federal or state program or other payer, or the entity that is responsible for purchasing the 340B drug. And those are not going to be the vendor.
Yes, absolutely. So I know we only have a couple minutes left, but if there's any questions from the crowd, I know we went through a lot, but I think it is really important, like I said before, to understand that there are many different rules and laws impacting the success of your overall program, and just be even awareness of some of these things that we've talked about today. And this is also supposed to be a really kind of high level of these other rules. For specific questions, obviously consult your attorneys. Call Emily.
Yes, there's a lot of nuance here. And again, a lot of risk continuum and
Yes.
the need to understand as an organization how comfortable you are with certain arrangements. I work with clients who generally take a very conservative approach, and so they have a very low risk tolerance and may be unwilling to engage in various arrangements that are extremely common across the 340B space. And I have other clients that are extremely risk tolerant and are willing to push the envelope pretty far to do things that other clients would very much be uncomfortable with. And so it's, again, important to understand that you understand the rules and are working with somebody who also understands the organization's risk tolerance and how it feels about putting itself out in terms of a potential enforcement action.
Yes. Absolutely. Suzanne, do you have questions?
Yeah.
Yeah, I guess my one question would be, okay, so I'm sufficiently scared and I'm at an organization and I've seen something on this list that I'm like, oh, that's a red flag for me. Who do I go to? Like, what's sort of the recommendation of?
Yes, so that's a great question. It is organization specific. There are a couple of things I will say. Organizations are generally expected to have some form of compliance reporting hotline or other compliance reporting process. So that may be a good place to go if you don't know where else to go. But generally, I would suggest reaching out to whoever within the organization's compliance or legal department you generally work with or is popping their head into various pharmacy or 340B issues. If they're not the right person, they will generally be able to get the concern to the right person. But I will also say, generally, you should not be concerned about raising issues. There should be a organizational culture that encourages flagging potential issues. I know that's not always the case, but again, it is critically important, particularly in the 340B space, because oftentimes the 340B staff are being tasked or are the only ones who know about potential arrangements or risk areas. Okay.
All right. Well,
Thank you
we will
so
be sending out
much.
a copy of the recording. Emily, as always, thank you so much for all of your expertise and time. We really appreciate it. And we will see you next month.
Great.
Bye.
Thanks,
everybody.
everyone. Bye.